Everyone knows us. I'm Miles,
I'm James.
And I'm Connor.
and we're going to talk to you even more about HIV and AIDS.
Surprising.
Yeah. So, Scott, I'm sorry. I'm going to tell you a bunch of stuff you already know. So, for some general background, human immunodeficiency virus, or HIV, is the source of acquired immunodeficiency syndrome. And it looks like this. This is actually an HIV virus. I mean, mixing with an immune cell. You can get HIV through four main pathways: unprotected sex, in utero from mother to child, and dirty injection equipment and contaminated blood transfusions are the main ways. It's a misconception that you can get it through saliva or urine or insect bites. So these are vectors that you don't have to worry about. So HIV works by infecting cells of the immune system which express a binding protein called CD4. And this diagram just shows the CD4 binding protein then attaching to the HIV membrane fusing. And cells that have this protein include dendritic cells, macrophages, monocytes, and most importantly, helper T lymphocytes, also called CD4 cells. And infection slowly diminishes all of the levels of these cells, and when they reach a critical level, essentially all cell-mediated immunity is lost. And that allows opportunistic infections to come in and thrive in ways that they couldn't before, including tuberculosis, toxoplasmosis, and Kaposi sarcoma, as Scott mentioned. And in fact, 25% of all tuberculosis deaths are related to HIV. This is, again, what it looks like. It has a membrane, a bunch of proteins that protect this RNA genome. The two most important proteins to look at are reverse transcriptase and protease. And here I'll mention that HIV is a retrovirus, meaning it reverse transcribes its RNA genome into DNA, which it then inserts into our own host cell's genome, which allows it to produce its own viral proteins, like HIV protease, which then performs post-translational modifications to the viral proteins, which then allow mature virions to form. So we combat this with highly active antiretroviral therapy. It's the most common and one of the most effective methods of fighting HIV. There are three classes of drugs involved in this. There's NRTIs, NNRTIs, and protease inhibitors. RTI just means reverse transcriptase inhibitor, and N and NN are just chemical distinctions, but they essentially do the same thing. So that's stopping the virus from inserting its genome into our own cells at the first level of prevention. And then protease inhibitors inhibit the proteases of HIV, preventing post-translational modification of any viral proteins that may actually end up being produced. So together, these types of drugs can fight the infection. Sub-Saharan Africa is one of the worst affected areas of the HIV pandemic, and South Africa has the largest population living with HIV at over 7 million people. This has been hurt because of HIV denialist movements in the region, where even in government, policies have been made and information has been spread about how antiretroviral medications are poisonous, which they aren't, and that, although there are side effects, and that HIV is not the cause of AIDS, for instance. So all of this is to tell you about a case of a 7-year-old boy in South Africa who contracted HIV in utero and went through an ordeal where just about everything that can go wrong with antiretroviral medication did go wrong. James, I'll tell you more about that.
So as we said, now that we know the general background of HIV and the biochemical processes behind it, as well as brief history, we can dive into our specific case, which Miles did summarize. This report was recorded at the McCord Hospital in South Africa by Dr. Tammy Myers. Okay, so we're going to start the case history antepartum before the child was even born, probably the most important event in his medical history was when the patient's mother received prenatal care but was never tested for the HIV infection. In fact, we see that the patient isn't even tested for the HIV infection until he's 5.5 years of age. But let's not get too far ahead. At age 3, we see that he's admitted to a hospital due to pneumonia. The initial diagnosis is that of tuberculosis, and as a result, he's put on anti-tuberculosis medication such as rifampin, isoniazid, and pyrazinamide. 26 months prior to this evaluation, the patient presents an episode of suppurative otitis media, which is essentially just inflammation of the middle ear. Here's a picture. You can see the incus and the tympanic membrane. A year and a half prior to this evaluation, here's where we finally see a test for the for HIV. He comes to he's readmitted to the hospital on counts of fever, cough, and abdominal distress. Initial skin tests for TB returned non-reactive, and as a result, they went out and tested for HIV. As we can see, there's a drastically low amount of T cells, as well as a drastically high amount of copies. The initial administration of antiretroviral medication included ritonavir, lamivudine, and zidovudine, and that regimen maintained until the evaluation conducted by Dr. Myers. Around a year prior to the evaluation, we see an improvement in T cell and RNA counts. However, a supraclavicular abscess has developed, which was not responsive to antibiotics. A biopsy test revealed numerous leukocytes, but no signs of microorganisms. And a further pathological examination revealed granuloma necrosis, which is consistent with active tuberculosis. And 8 months prior, he is finally referred to the McCourt Hospital, in which Dr. Meyer was attending, to renew his retroviral medication. Here, they learned a little bit more about the history of the patient growing up in a single-family household, where it is assumed that his father passed away due to complications with HIV. It is also revealed that the patient is unaware of his illness. He doesn't know he has HIV. And his mother and his grandmother stick him to his medicine. He's reported to follow his medical regimen. And then we skip to the evaluation. Here we see the updated T cell and RNA counts. And at this point, we see a change in the type of medical regimen, the antiretroviral medication. Now, ritonavir alone is replaced with a lopinavir and ritonavir combination therapy, as well as increased dosages of zidovudine and lamivudine, as well as the administration of multivitamins. And in the post-evaluation, we see an improvement in T cell count, still change in RNA count, but overall, he's returning to pretty normal or improved white blood cell counts and platelet counts. Which leads us to our differential diagnosis, which we concurred with Dr. Myers, which was that there was an improper retroviral medication regimen, as well as an ineffective combination of medications, which resulted in this high elevated RNA level.
All right. So now I'm just going to, now that we have sort of the history of the case, I'm going to go into a little bit more detail about sort of the things that went wrong in the handling of this case, and then what was done to correct that later on. Oh, this is just a table detailing the patient's height, weight, and medications. But so the problems, the sort of most glaring oversight in the treatment of this patient was that despite receiving prenatal care and living in a high-risk area, his mother was never tested for HIV while she was pregnant. Now, had this been done, it would have been relatively easy for them to prevent the child from becoming infected during his birth and as an infant. And he was then not officially diagnosed until he was 5 years of age, despite presenting with symptoms consistent with tuberculosis at the age of 3 and suppurative otitis media several months later, which are both common opportunistic infections. HIV testing was not done on him until the age of 5. So sort of to the best way to increase survival rates among children and infants infected with HIV is to diagnose them as soon as possible so that treatment can be done. And sort of to facilitate this, national guidelines in South Africa and international guidelines are now suggesting that all infants living in high-risk areas sort of preemptively start taking a course of antiretroviral medications, and that all infants presenting with possible opportunistic infections immediately receive HIV testing. So another problem that occurred in the treatment of this patient is the problem of adherence. So his mother was never trained in adherence to a antiretroviral regimen, and the importance of sticking strictly to the treatment plan. And this was sort of compounded by the fact that the patient was never told about his diagnosis, and so was sort of unable to, I guess, understand the importance of his treatment and be more actively involved in his own care. And then another thing that was done incorrectly on the part of the doctors was there were some major problems with his initial antiretroviral regimen. So normally a mix of 2 NRTIs and one NNRTI or a protease inhibitor is prescribed. And this sort of mix is done to make it less likely that drug-resistant strains will be able to develop. Now, the regimen he was initially prescribed consisted of 2 NRTIs and the protease inhibitor ritonavir. However, ritonavir is not recommended as the third drug in this particular course for several reasons. One of which is ritonavir on its own, when not paired with another protease inhibitor like lopinavir, has been shown to increase the rate of mutations among the virus. So this makes it more likely that drug-resistant strains will develop. And it is also not recommended for use alongside the medications he was receiving to treat his tuberculosis, nor is it recommended for his age group, as it is relatively unpalatable and children tend to dislike it, making them less likely to adhere to their treatment. So the drug that was recommended as the final antiretroviral in this regimen is the NNRTI efavirenz. And he was later switched to that, but it did take over a year before he was actually put on the correct regimen. And his initial regimen, the final thing that sort of went wrong was that his initial regimen was not changed to reflect his growth as he, sort of got older and bigger. His doses were not increased, and they were also not initially changed when unchanged viral RNA levels suggested that his infection had developed some resistances to the regimen he was receiving. So to solve this, because it became clear that his infection had developed several drug resistances, it was necessary to switch him to a new regimen. He was switched to the non-peptide protease inhibitor duranavir and the NNRTI efavirenz, and the NRTIs being used were also changed, as it showed that, or as the genotyping of his infection showed that he has developed resistances to several drugs that he was already on, and several other similar drugs. So this genotyping was done to find a regimen that would work for him, and his new regimen was successful in achieving viral suppression. So So now that he was on the proper regimen and his viral RNA levels were decreasing, the next problem to be solved was the problem of adhering to the treatment plan. So in the future, it will be necessary to inform the patient of his diagnosis so that he can be more actively involved in his own care and understand the importance of adhering to his treatment plan. And it was also recommended by Dr. Myers that the patient join a support group, sort of learn more about ways to live with this disease from other people that have it. And his mother did also eventually enroll in adherence training to sort of, because she is his primary caretaker, to aid in the adherence to his treatment plan. So some of the ways that it is hoped that HIV will be combated in the future is there are several methods of developing an HIV-1 vaccine that are being investigated currently. One of the most promising ones uses AAV-delivered ECD4 Ig, which is a fusion of a CD4 immunoglobulin and a small CCR5 mimetic sulfopeptide. And what this does is it binds to some of the glycoproteins on the HIV-1's envelope and prevents it from being able to enter the cell. And there are several other similar mechanisms that are being investigated to potentially yield a vaccine for HIV-1. Thank you.
Anybody have some questions? I have. So I just want to understand some stuff. First of all, why you say that ritonavir increases the rate of, and this is, I want to understand this. This is different than antibiotic resistance, right? So antibiotic resistance, we heard Dr. Gavin last night talk about antibiotic resistance. Don't finish your course, it kills the bacteria, but a few that are not really susceptible to it survive, and if you don't go all the way and really blast them, you're selecting for ones that are less susceptible to the drug. But you are saying something different. You're saying that ritonavir increases the rate of mutation. Why? I don't understand. I really don't. Did you come across some sort of thing that's?
I don't think I did. Did you guys?
No.
But I was gonna say, like, if I had to venture a guess, I would say it's possible that the way the specific ritonavir interacts, it's possible that it's affecting reverse transcriptase, but then there might be.
Go back to that diagram.
Oh, yeah.
It's interesting.
So it's coming into this green dot, right? And it's going to inhibit that. Mm-hmm. If I had to think of why it would increase risk of mutation without a partner, potentially there might be moments when like it binds improperly, or maybe it interacts with some other system and triggers another protein to do something it's not supposed to. I'm just thinking maybe there's like a percentage of the time that it does work correctly, and then another percentage of the time that it's actually causing a change in the DNA, for instance, and actually not completely stopping transcription. That would be my hypothesis.
What is CCR?
CCR5, it's another so it's a sulfopeptide, right? Like that's what it says there. It is a protein chain or an amino acid chain with some sulfate groups in it that
Sulfopeptide is the thing. Is a sulfopeptide is some other thing that they're pharmaceutical.
Yeah, it's being created to mimic CPR5.
CCR5, the binding partner.
Yeah.
Of
Right. It's the epitope, the antigen for this glycoprotein.
It's the binding.
Yeah. So the glycoproteins of HIV have multiple binding sites, and CCR5 is just I believe, a peptide that interacts with that binding site.
What?
Two things. First of all, great. Reverse transcriptase messes up a lot. It's not great at what it does. So one of the reasons they're Norvir, brand name, and other meds is because of the inability of reverse transcriptase to actually do it correctly. And so CCR5 is a co-receptor. That's one of the ways we're going to cure for HIV by interrupting the ability of the virus to get the doorway by that. So that question is so important. When a cure comes out, it's going to be because of those letters, CCR5.
Mm-hmm.
That's going to be the reason for it and the ways in which we do it. But I have a question for you about the slide before the one to do with before this one. He talked about the new regimen for the boy having, he was told to be on meds. All babies born in are now put on HIV medication.
That's the recommendation is that children living in high-risk areas be put on some sort of antiretroviral medications.
Whether they're tested for HIV or not.
Without being tested, yeah.
Why would that?
I think this also might be a history problem because this is a almost 10-year-old paper. So I think this is something that we should disclose. Like, this is a 10-year-old paper. It's likely that the recommendations have changed. I don't know if 10 years ago the situation was worse and there was like higher incidence of in utero transmission. And I know actually it has decreased significantly in the last 10 years. I think it's down like 18% in South Africa since then.
Just logically, it makes more sense. It's cheaper to get tested than it is to get access to medication.
Right.
Children who don't even need it.
Mm-hmm.
Our last question is this: and whatever happened to the treatment for the mom? Because there's lots of stuff going on for the treatment. The mom is that's how the baby got it.
Right.
So did she get? Do you know anything about her treatment?
I can take this one. So she was obviously diagnosed with HIV as well at the same time he was, but unfortunately the paper doesn't really go into her treatment. It mainly focuses on the child.
Okay. Thank you.
Thank you.